We're just trying to share the screen. Sorry. Downloads, but I don't know. Okay, it's not allowing me to go to my documents, Prof. Sorry.
You basically just have to share, open the document and then click on share screen. Otherwise, you won't see it. Open your presentation first, then go to share screen.
Okay.
So close the share screen and then open the document, then open your share screen and then you should see it.
Okay.
Got it. Click.
Just a second.
You sent it to me. Perhaps I can just help and do it for you.
Okay, I'm sharing it.
All right.
Okay, maybe let's just use yours, Prof.
Okay, 2 secs. Just tell me next when you want to be next.
Okay. Can we start, Prof?
Yes, proceed.
Okay, good afternoon, everyone. My name is Begitemba Mazibugo. I'm along with Abongile Tanga and Notando Makwaza. So we'll be presenting monitoring evaluation framework, clinical governance, and key health indicators in planning. Can we proceed to the next slide, please? So our presentation is going to be outlined like this. So I'll be covering monitoring and evaluation. Abongile is going to be covering clinical governance, and then Tando is going to be covering health indicators. Can you go to the next one, please? So monitoring and evaluation by definition is a regular, systematic and collection and analysis of information to track progress of a project, program, or a service. While monitoring seeks to explain what is happening, and evaluation attempts to explain why that is happening. And this is going to help us to learn and share important lessons. So in essence, monitoring and evaluation shows whether a service or program is accomplishing its goals or not. It identifies the program's strengths, weaknesses, as well as the program the needs for the program to be revised, and if the program is meeting or is exceeding its expectations. So I'm going to go to, okay, can we go to the previous slide, Prof? So I'm going to talk about monitoring first. So monitoring by definition is a continuous process of collecting and analyzing data on information to compare how well a project, a program, or a policy is performing against all expected results. Then you can get to the next one. So I'll be just going through the different types of monitoring. So the first type of monitoring would be performance monitoring. So the purpose of this type of monitoring is to provide the management and leadership with ongoing comparison of the current reported performance outcomes against all the planned targets. So this type of monitoring also aids with the use of appropriate systems to generate a timely and accurate reports. For those reports to be reviewed quarterly to ensure that fiscal and performance goals are being met. So, and then next I'm gonna go to compliance. Sorry, could you please go? Yeah, I'm gonna describe all of them and then I'll just ask you to go to the next slide, Prof.
Yeah, you tell me next, then I'll take the cue. Thanks.
Yeah. So now I'm gonna describe compliance monitoring. So compliance monitoring ensures that the legal mandates and other policies are being met as described in their scope of work. So it ensures that all activities, operations, and administrative processes are in compliance with all their requirements, and it monitors compliance of all funded programs, which also include the following. So reviewing program administration, fiscal and management practices, internal program management, as well as prevention of fraud and abuse, and also assesses the compliance to legal mandates. Quality monitoring. So the purpose of quality monitoring is to review the integrity and efficiency of the program and the effectiveness of the health process of the health services provided. It also analyzes problems identified through the performance monitoring. So desk reviews and monitoring findings so that corrective actions are in place with specific recommendation that can be developed. So it also assists in determining what technical assistance may be needed and provides a program or a project with an opportunity to ensure that corrective actions are occurring, compliance is achieved, and program performance is enhanced. So primarily the focus shall be on what is happening, why that is happening, and how it is improved, just to ensure that the program is good quality. So frontline monitoring is essentially a desktop review through briefing sessions, inspections, review of documents, staff and clients interviews, observation, and feedback. We can go to the next slide, Prof. So evaluation, can go to the next one. So by definition, evaluation is a process which attempts to determine and systematically and objectively as possible the relevance, effectiveness, efficiency, and the impact of activities in the light of specified objective. The intent of evaluation is to incorporate lessons that are learned in the decision-making process. So the next slide, please, Juan. So evaluation may focus in different aspects of a service or a program, such as inputs, activities, outputs, and outcomes. I'll just go through the definitions of all of the above mentioned. So inputs would be all the resources that contribute to production of the service delivery. So in essence, they are what we use to do the work. For example, finances, people that we use, equipment, building that are going to be using for the programs. So activities are the process or actions that are used to produce the desired outputs and ultimately the desired outcomes. So in essence, they describe what we are going to be doing. So outputs those are the immediate results of activities that are conducted. They are final products, goods or services that are produced for delivery. So outputs in simple terms can be defined as what we produce or what we're gonna deliver. So outcomes are medium-term results for specific beneficiaries, which are a consequence of achieving specific outputs. They are short-term effects related to the objectives that we have. So essentially, they are what we wish to achieve at the end. Can we go to the next slide, Prof? So now I'm going to talk about the different types of evaluation. First one would be self-evaluation. So that would be a self-assessment of programs by departmental human resources. And secondly would be participatory evaluation. So these are internal evaluation in a form of peer review. If you have people that are from outside, then they can act as facilitators of the process, but then they are not allowed to evaluate, or they are not evaluators in that sense. So interactive evaluation is active interaction between an outside evaluator or evaluation team and the department or project that is being evaluated. And then baseline surveys and ex-ante evaluations, those are conducted to obtain the available information about the situation before an implementation of a project. And it's very difficult to measure impact of any initiative if the situation is not known prior to the commencing the implementing whatever program that you are gonna be implementing. So then we go to midterm evaluations. Those shall be carried out in the middle of the implementation of a project. So for example, if a project is gonna be 1 year, so within 6 months, then you do your midterm evaluation. So, and then also ongoing evaluation shall be conducted during the implementation of the operational program, which shall concern the efficiency of the use of public resources and effectiveness of the implementation system. And then we're going to look at ex post evaluation. So those evaluations shall be carried out not later than a year after completing the implementation of a plan or a program, and it shall sum up and evaluate the intervention once it has been terminated. The evaluation shall be carried out by independent experts in cooperation with Provincial Monitoring and Evaluation Division. You can go to the next slide, Prof. So this is just a picture or a graph that shows the lifespan of a project and how evaluation should work. So as I've described before, I'm not just going to go in detail. So firstly, you're going to have the baseline, which is the ex ante evaluation. And then as the evaluation goes on, at the middle of the program, then you're going to do the midterm evaluation. Then once the program is completed, then you're going to do a final evaluation. And then a year, not later than a year after that, you're going to do an ex post evaluation. Can you go to the next one? So I'm just now going to be talking about the correlation between monitoring and evaluation. So while monitoring clarifies program objectives, evaluation analyzes why intended results were or weren't achieved. So while monitoring also links activities and their resources to objectives, evaluation assesses specific causal contributions of the activities to the result. So while monitoring translates objectives into performance indicators and set targets, evaluation examines implementation process. So while monitoring routinely collects data on these indicators, compares actual results with targets, evaluation explores unintended results. So while monitoring reports progress to managers and alert them to problems, evaluation provides lessons, highlights significant accomplishments or program potential, and offers recommendations for improvement. So we can go to the next slide, Prof.
All right, my name is Abongile, and I'm gonna be talking about clinical governance. So clinical governance, it's a framework that helps managers and clinicians to improve the quality of their services and safeguard standards of care in continuous, thoughtful and coordinated fashion by creating an environment in which excellence in clinical care will flourish. Next slide, please. So in simple words, clinical governance is an umbrella term that is used for everything that helps to maintain and improve high standards of patient care. In order for this to work, every healthcare facility employee needs to recognize their role in providing high quality care. Patient care needs to be improved using whatever method that is most suitable. For example, by identifying aspects of care that need improvement, making plans to improve them, and monitoring your success. The success should be monitored in order for this to work. Learning from past experiences is also very important. Not only that, but also to move away from the culture of blame to a culture of learning. Next slide, please. A number of our patients in the public sector have had awful experiences in some of the hospitals, be it that they may have been ill-treated by healthcare workers or witnessed the below-par services rendered to their loved ones. Due to this, patient experience should be at the heart of clinical care. Also, there needs to be accountability at all times. And most importantly, clinical governance is about developing true partnership between managers and clinical staff, and between clinical staff and patients. As we all know, the country that we live in, healthcare varies across regions and facilities, from facilities being underdeveloped to having very limited resources. The quality of care in many facilities is not as good as we would like it to be. However, there are promising initiatives underway to strengthen primary healthcare, the PHC's approach, to improve the building blocks of the healthcare system. With all that being said, yet many healthcare workers are demoralized because there seems to be little improvement despite the fact that they're working hard and giving off their best. That's where clinical governance comes in. Healthcare workers reflecting on how they work, envisioning new possibilities, and finding ways to improve the outcomes of their efforts, even in very challenging circumstances. Next slide, please. So this slide over here shows the 7 pillars of clinical governance. It's clinical effectiveness, information, risk management, education and training, audit, patient and public involvement, as well as staff management. Next slide, please. So just to highlight a few, clinical effectiveness is all about ensuring that everything we do is designated to provide the best outcomes for the patients. Basically, it's the right thing to the right patient, by the right person, at the right time, and at the right place. Then, next slide, please. Then the staff management. Staff management is mainly about the appropriate recruitment and management of staff, also ensuring that underperformance is identified and it is addressed, as well as providing good working conditions for the workers. Risk management, it's systems in place to understand and monitor, as well as minimize the risks to patient as well as to staff, as well as to learn from previous mistakes. Next slide, please. So education and training, it's basically about reading to keep up to date with the latest evidence, as well as guidelines, as well as providing appropriate support to enable staff to be more competent in what they're doing, to make sure that they've got the required skills and that they're up to date with everything. And with regards to patient and public involvement, this is ensuring that services are meet the needs of the patients. So with this being said, the complaints system is very, very important, as it helps in the as it works as an improvement opportunities, because the complaints that you get from the patients can help you improve on what you're lacking, the feedback they give, as well as, you know. Next slide, please. Next slide, Rob. Next slide, we'll skip this one.
Hi guys, my name is Notando. I'm going to be talking about the health indicators. So health indicator is a variable susceptible to direct measurement that reflects the state of health of people in a community. It helps to measure the extent to which the objectives or targets of a program are being attained. Next slide, please. So we have a couple of characteristics that you should see when using the health indicators. One of them is that the health indicators should be valid. They should actually measure what they are supposed to measure. The definition must be precise and easy to understand about what it is that is to be measured. They should also be reliable. The results should be the same when measured by different people in similar circumstances. They should be accessible, meaning the data should be collected easily on a timely basis at a reasonable cost. They should be sensitive to changes in a situation concerned, and specific in a way that they should reflect changes only in the situation concerned. They should be feasible, showing the ability to obtain data when needed, and useful. The data should be utility for decision-making and learning, and they also should be relevant, which should help to contributing the understanding of the phenomenon of the interest. Next slide, please. So there are 4 questions that you should ask that should help you to determine an indicator. How will I know if the objective has been accomplished? What would be considered effective? What would be a success? And what change is expected? Next slide, please. So the uses for health indicators are measurement of the health of the community, description of the health of the community, comparison of the health of different communities, identification of health needs and prioritizing them, concurrent and terminal evaluation of health services, planning and allocation of health resources, and measurement of health successes. Next slide, please. There are classifications of the indicators. So there's quite a few, and each and every one of them are pretty extensive. So I'm just going to go through a few, but just to name them, it's mortality indicators, morbidity indicators, disability rates, nutritional status or nutritional status indicators, healthcare delivery indicators, utilization rates, indicators of social and mental health, environmental indicators, socioeconomic indicators, health policy indicators, and indicators of quality of life, and other indicators. Next slide, please. So when going into mortality indicators, we have a couple of definitions under that, like the crude death rate, which is considered a fair indicator of the comparative of health of the people. It is defined as the number of deaths per 1,000 people per year in a given community, usually the immediate population. The usefulness is restricted because it is influenced by the age, sex, composition of the population, socioeconomic and sociocultural environment of the communities. Next slide, please. Also life expectancy, which is the average number of years that will be lived by those born alive into a population if the current age-specific mortality rate persists. So this is a statistical abstraction based on an existing age-specific death rates. It is estimated for both sexes separately and is a good indicator for socioeconomic development. Next, please. So Stats SA published a document sometime this year, which states that the population of South Africa was estimated to be 60.14 million, at mid-year 2021, and an increase of about 604,281, which is 1.01% since year 2020. The latest media population estimates in 2021 released by the Stats SA shows that the COVID-19 pandemic impacted mortality and migration in the country since the start of the pandemic early in 2020. So South Africa experienced both peaks of deaths in the first and second waves of COVID-19 pandemic within the 2021 media population estimates period between July 2020 and June 2021. This resulted in a significant increase in the crude death rate from 8.7 deaths per 1,000 people in 2020 to 11.6 deaths per 1,000 people in 2021. The significant rise in deaths in 2021, which was approximately 34%, meant a drop in the 2021 life expectancy at birth for South Africa. Life expectancy at birth for males declined from 62.4 in 2020 to 59.3 in 2021, which was a 3.1 year drop, and from 68.4 in 2020 to 64.6 for females, which was a 3.8 year drop. Whilst the life expectancy at birth indicator is an important health indicator, in this COVID period, it should not be interpreted as a projection of an individual's lifespan, but should rather be used to shed light on the cumulative burden of a crisis compared to recent trends. Next slide, please. So this is basically a map showing the decline in the life expectancy due to COVID-19 pandemic. It shows that from between 2002 to about 2009, the life expectancy, 2006 rather, was attributed by the impacts of HIV and AIDS. And then now, between 2020 and 2021, it was due to COVID. Next slide, please. So mortality indicators. Continuing with mortality indicators. There also is infant mortality rate, which is the ratio of death under 1 year of age in a given year to the total number of live births in the same year, also usually expressed as rate per 1,000 live births. It is an indicator of a health status of not only infants, but also whole population and socioeconomic conditions. It is sensitive indicator of availability, utilization, and effectiveness of healthcare, particularly perinatal and postnatal care. And in 2019, it was estimated to about 27.5 deaths per 1,000 live babies. Unfortunately, I couldn't get the recent one. There's also under 5 mortality rate, which is defined as number of deaths occurring in the under 5-year age group per 1,000 live births. It also reflects both infant and child mortality. Child mortality being the number of deaths of ages 1 to 4 years in a given year per 1,000 children in that age group at the midpoint of the year. It correlates with inadequate maternal care health services, malnutrition, low immunization coverage, and environmental factors. Other indicators were perinatal mortality rate, neonatal mortality rate, stillbirth rate, etc. Which correlates. It also correlates with inadequate antenatal care and perinatal care, as mentioned before. We also have maternal mortality rate ratio, which is the ratio of deaths arising during pregnancy or puerperal period per 100,000 live births. It accounts for the greatest number of deaths among women of reproductive age in developing countries. So also disease-specific death rates, which is the mortality rate, which is computed for specific diseases. We also have proportional mortality rate, which is all deaths attributed to a specific disease. Next slide, please. Oh, yeah. We also have morbidity indicators, which reveal the burden of ill health in a community, but do not measure the subclinical inapparent disease states. And under this, we have incidence and prevalence as the first one, which is the number of new events and new cases of a disease in a defined population within a specific period of time. That is the incidence. And prevalence is the total number of individuals who have an attribute or disease at a particular time divided by the population at risk of having attributes or disease at this point of time. It also reflects the chronicity of the disease. We also have notification rates, which is calculated from the reporting to public authorities of certain diseases like yellow fever, poliomyelitis. They provide information regarding geographic clustering of infections, quality of reporting systems, etc. There's attendance rates at OPDs and at health centers, admissions, readmissions, and discharge rates rather, duration of stay in hospitals, spells of sickness or absence from work or school, which reflect economical loss to the community. Also, there's hospital data which constitute a basic and primary source of information about a disease prevalent in the community. Next, please. We also have a nutritional status indicator, which is a positive health indicator. So here we measure newborns for their birth weight, length, head, and head circumference. They reflect the maternal nutritional status. There is also anthropometric measurements of preschool children, where we measure weight, height, and mid-arm circumference. Next slide, please. Yeah, we also classify the babies as underweight, where it's weight for age less than -2 standard deviation of the World Health Organization child growth standards median. Also stunting, which is height for age, which is less than -2 standard deviation of the World Health growth standards median, and wasting, which is weight for height less than -2 standard deviation. Also the overweight, which is weight for height, which is more than +2 standard deviation of the World Health Organization child. So we also do growth monitoring of children by measuring weight for age, height for age, as mentioned before, head and chest circumference, mid-arm circumference. In adults, we classify them as underweight, obese, or anemic, which are generally considered reliable for nutritional indicators for adults. So that is the end of our presentation. I couldn't go through all the other indicators because there's quite a lot of them.
Yes, no, thank you. I think, the idea is to get a sweep of understanding, and you are almost left to your own devices. So, and it's fair. Thank you very much for the effort. Let's just get a quick sense of how people rated it. So let's just redo it. We launch the poll. Here we are. Give them a scoring. How well do they think? So while you're scoring, I just want to give you some comments. Essentially, when you get to, and let me stop sharing this. All right. When you're looking at clinical governance as a concept, it actually is a UK concept. Started off in the UK, and it started off because the big challenge was that managers who were not necessarily very familiar with clinical work were doing things, but they were failing to address the outcomes that satisfied clinician and patient level outcomes. So you can see that in terms of the way in which you've described clinical governance is very focused on the clinical outcomes as well as the patient level outcomes. A lot of the emphasis also on safety, which has been a growing concern in UK and other countries like that. Similar ideas in the US and other parts of the world. So clinical governance, common term, we use it as a way, as family physicians, as a way to emphasize the need in the district health service for doctors, family physicians, to play a more meaningful role in the overall management. And one of the difficulties we have in the primary healthcare section service is that nurses who run services seem to forget perhaps the clinical issues and be driven by the management prerogative and fail to see that what they're doing undermines the clinical purpose. And so we as family physicians have tried to emphasize clinical governance and our role in terms of, asserting ourselves in a way as clinicians go. So I think understand that. So I'm going to stop the rating, and you can see your results. Good to very good. Thank you very much for all that feedback and the work. One other comment, one or two other comments, is that when you're sitting and looking at indicators, and it would have been better to have gone about it in this sort of process. An indicator is something that you need to take out of broad guidance, like guidelines and other standard or places where you say this is what we expect to happen. And so you say, well, let me then translate that into an indicator. And you very rightly pointed out to the fact that indicators need to be smart. You went through it a little bit more, but think about smart, specific, measurable, accessible, relevant, and time-based. And I think that one day, many of you will be involved in some sort of accountability in which you have to reflect on that question. I'm being held to account for this indicator. It might be in the private sector, it might be in the public service. It can be varying by discipline, but you'll be asked to report on that or report on it. You need to be able to ask yourself that question: is this actually the best tool? So when you get to the question or the issue of what was presented as evaluation and monitoring are really monitoring. I think the issues of thinking through this question of inputs, activities, outputs, and outcomes are very important, especially in the public service, where a lot of our monitoring and evaluation is around, and in fact, mostly monitoring. So if I were to just share with you in the public service, there's a lot of monitoring going on, very little evaluation. And evaluation is mostly good research, and it doesn't happen very well. But monitoring is what is going on quite considerably, and it's using the district health information system, which is the tick sheet that you're putting every day ticks on, which again, you must ask yourself, well, who else is putting ticks on? And that is what you are actually collecting as your data, goes into a system, comes out as DHIS reports. And when we're looking at the pap smear project, we're going to show you in about a week or two what is going on broadly around some of these indicators. But what you'll see about some of these indicators is that the public service puts a lot of emphasis on input, In other words, how many condoms have been distributed? How many meetings have you had? How many visits have you had? So these are not, they are inputs and activities. They're not outputs. They're not something that you get as a result of an activity. So did you get people who are educated, or did you get people who are healed, or did you get people who have taken their complete treatment? With TB, there is that follow-up, but diabetes, there's nothing to say, are we actually having control? Are people having less complications of diabetes? There is some element of that with HIV, are they having virally controlled, their viral loads controlled in some measure, but it's very segmented. HIV is the big bugbear, so everybody's focusing on that, huge amounts of energy on it in the public service. But for lots of the rest of the service and the routine approach of the service, very, very limited. So when it gets to this monitoring, outcomes are not showing. And again, you need to ask yourself, if I'm going to collect data, I want it to be meaningful. If we are going to have input level data, then it's a very micromanaged situation, and that's really the public service. So just understand that. In evaluations, the same approach as you would with any bit of research, you need to think more deeply about it. So yes, it is about understanding whether you've got outcomes and what exactly have been the pros and cons of what you've been trying to do. So I hope this has helped you to understand it. We will be talking to these issues in the as we're going along, particularly around the QIP. The family physicians in the district, Dr. Aki, for example, was busy trying to put together the strategic plan of family medicine in the district, for which he was supposed to report. And this requires you to think very carefully, because a lot of the focus in this strategic plan is on what are you showing for in monitoring, not so much evaluation. Should be there, but it's not. And that, how do you spell it out in a way that is very clear what exactly is this indicator? How do you actually get this information? Because one of the problems is that you can try to speak to outcomes, but the problem is the indicator, the data that speaks to the results. So that's kind of part of the challenge when you are sitting one day and having told, try and draw up a strategic plan for your unit or your area or whatever. You've got to be able to say, well, what am I doing? But actually, what is the outcome? What do I want to see happen at the end of it? That's my objective. My activity is simply a way to get there. But what am I trying to achieve? And of course, we were talking about, should we be in the diabetes, talking to diabetes control? But the problem is that that data is not routinely available, so we can't monitor it. What we said is, what we could do is we could actually say, we are going to see, start simply with how many CHCs get audits of diabetic treatment or diabetic management in the charts. So it would be a sort of very simple audit of files per month or quarter of files that would then be able to say, well, we did it. And at this point in time, we're not even looking at whether that is good or bad. We're just saying, was it done? And because that is reasonably easy to achieve, and we can monitor that. Once one gets some way up in terms of outcomes, where, right, our outputs is that every CHC, 11 CHCs, all of them start having these audits done, then you can say, well, now let's take it a layer down. Let's look at what is the outcome of that audit. How many people, when we look at the audits, how many charts have got it and not got it? And can we report on that? So can we take our next year or the next cycle of reporting down to the level of, can we get a report on compliance and non-compliance of good management of diabetes? And then we might go further to say, well, are we then looking at specific indicators of management within it? So I hope it impresses on you that this can be quite difficult to do, and you will be tasked somewhere, because of the strengthening of clinical governance across the world, of being able to think about what it is that I should be writing and putting together as a strategic or an operation plan for something that I am responsible for, or a team I am responsible for. So hopefully this gives you some some sense of it. We'll probably be going through a little bit more of this